It was indeed an honor and a privilege to be invited by All India Ophthalmic Society Scientific Committee to talk on Toric ICL. So in this video, I'll be sharing my 6-minute presentation on Toric ICL. It will be beneficial for postgraduates and ophthalmologists who tend to start doing ICLs for their patients.
So now we have in line Dr. Sagar Bhargav, and I will introduce Dr. Sagar. So Dr. Sagar Bhargav is a senior consultant in the BBI Foundation, Kolkata, and director in the SLR Eye and Retina Surgeons Private Limited, Kolkata. He was the university topper in the first MBBS and won several awards. After finishing his MS, he joined Shankar Nethralaya, Chennai as a fellow and then the consultant, and he was recognized as the best associate consultant in 2008 in Shankar Nethralaya. Besides his clinical practice, he is now actively involved in various academic activities and has many presentations and publications to his credit. And I would like to invite Professor Tatyal and Dr. Sanjay Chaudhary to please be the expert panel for this presentation.
Yeah, is my screen visible? Am I audible?
Yeah, you are both.
Yeah, you are audible.
Yeah, thank you. At the outset, I would like to thank Dr. Partha Bishwas and AIS Scientific Committee for giving me this opportunity. It's a privilege. So the topic that I'm going to do is Toric ICL. So as we know that Toric ICL, the pre-ICL work has already been dealt with very nicely today. But I would just like to give some emphasis to the points which are relevant to Toric ICL. The first very important point is that if the patient is a chronic contact lens user, it's preferable that patient should be off lenses for 2 weeks before you do the evaluation for these patients. You also need to do dry eye assessment, simple tests like Schirmer's, T-Bert and corneal staining, just to make sure that this ocular surface issues are not changing or not affecting patient's refraction. A tomography would be required to just rule out subclinical keratoconus, and you need to correlate also the axis and magnitude of the cylinder. The fourth important point that we have to remember is that when we are putting Toric ICL, we are actually treating the spectacle astigmatism and not the corneal astigmatism, as is the case in Toric IOLs. Now, to explain this, let me give you an example. This is a 28-year-old high myope with who was using -10, never used any astigmatism correction, but see the retinoscopic value and see the keratometrics, a very high cylinder. Now, how has this happened? So a topography would give you an answer for this. So you can see a hot spot there, just superior to the center, and that was good enough for the instruments to pick up a cylinder, but it did not cause any effect on patient's refraction, and patient was just needing a spherical correction. So in this case, we just went in with a spherical ICL, and this hot spot was because of some subtle opacities which were present in the patient's cornea. So this is very important to remember, that you have to basically aim for a spectacle astigmatism correction rather than corneal astigmatism. Now, the next important point is marking. So marking is essentially just like a standard Toric ICL, which all of us are absolutely used to doing, and use whatever the technique you are comfortable with, be it slit lamp, be it bubble marker, be it smartphone app, or be it digital marking. I, for one, usually use a smartphone app by Dr. Patwardhan, which is very convenient and very easy to use. And off late, because of availability of Varion at our center, I have now shifted to digital marking, which removes all the hassles, and it's very convenient. So let me share with you a case. This was a 36 to 35-year-old lady who came for an opinion for ICL, and this was the refraction of that. She was wearing a glass of -16 with 1.25 cylinder in right eye and -11 with 1.5 cylinder at 180 degree in the left eye. The visual acuity was 6/24 and 8 and 6/9 and 6. And the first thing we advised was to discontinue contact lens for 2 weeks, and we called the patient again. And look at the refraction that has changed. Almost one diopter increase in the sphere in the right eye, and cylinder also increased in the left eye. There was an increase in cylinder. We did a white to white measurement using Aladdin tool, which we have been using for last almost 4 years, and we find this quite convenient. It gives you both manual as automated as well as manual. Manual, if you feel that automated is not up to the mark, you can just adjust it and get the values. And this was how the topography looked like, an absolute regular astigmatism, and pupil size was also quite okay, and all the other measurements were within normal limits. So we started, we planned for an ICL for both the eyes, Toric ICL. So this is how the lens power calculation sheet looks like. And when we take the patient in the OT, we have to use this what is called as implantation orientation diagram, which is slightly different from an toric IOL. So here the concept here is that the company people will tell you to kind of insert the lens with respect to the horizontal meridian. So it either you have to rotate it counterclockwise or clockwise, depending, and the degrees is what they will inform based on the calculation. So here there is a counterclockwise 16-degree rotation in which we need to implant the lens for the right eye. Now let's look at the video. So we just seen the various insertion techniques. So I have my own little modification of the insertion technique. I don't use the forceps at all. In fact, I just load the lens and do a very small nudges to just push the lens in. I've been using this technique for almost a couple of years, and I find this is very convenient for me because I always fear that pulling the lens out with the forceps, might tear it or something might happen. So that technique works for me. Just gentle nudges and just bring it to the tip, and then it's ready for implantation. So here we are just marking about 15 degrees, and this is the lens which is coming out now. And I use a iris spatula in the other hand, and just to make sure that there is a gap between the lens and the cornea, just to keep it away from the cornea. And the same iris spatula, you can actually push it in. You do whatever technique you are convenient with. But the idea is that you need just gently nudge the foot plates behind the iris, and the lens gets into the position. And the marks are there, so you basically need to now orient the marks, and we do it in irrigation aspiration mode. And it's not very difficult to rotate these lenses, and the advantage here is that you don't need huge rotations. The rotations are usually between 10 degrees or 20 degrees. So it's a binomial method. You can just rotate the lens and bring it to the desired axis. So this was the endpoint. Here the issue here is that you should not allow the anterior chamber to collapse at the end. So just to make sure that everything is fine, and a little burp maybe just to make sure that it's not over inflated. And we did the other eye also of this patient, and we got a good result. It was a plano N69 N6, and this was the vault of the right eye around 524 microns. So I would conclude by saying that toric ICL definitely gives a very predictable outcome. Preoperative refraction is the most important thing. So a lot of due diligence should be given to preoperative refraction, and toric ICL marking technique should be mastered before you start doing toric ICLs. I think that's it. Thank you for your patient hearing.